Good afternoon, everyone, and welcome to our latest episode of the COVID Ethics series, Resource Allocation, What We Learned and What We Still Need to Learn. My name is Bryan Pilkington, and I moderate these sessions. To those of you who are regular listeners, welcome back. If this is your first time hopping on with us, welcome. I'm very excited about this conversation that we'll have. We have four excellent panelists to talk through some of the challenges and considerations related to resource allocation during COVID. As we get closer to, and in some places start seeing the second wave, and as some places are seeing their first real initial surges, this is an excellent time for those thinking about these issues to talk through challenges in resource allocation. If you are new to our program, the aim of the COVID Ethics series is to get folks from different backgrounds, different walks of life, to think through and practically reason together about a challenging ethical issue. So we have folks with different focuses and different perspectives who will be joining us for our conversation today. We'll hear from each of them, and then we'll move to our question and answer session. A number of folks have sent in questions via email, and you can tweet questions to us as well at Bioethics. I'm grateful for collaborations with the IHS Library, with IHS Student Services, and all the folks at Seton Hall and Hackensack Meridian Health in our med school who helped make this program possible. And there I am. And now we're going to move to our first panelist, Jason Ebrel. Jason is Professor of Healthcare Ethics and the Director of the Albert Gnegi Center for Healthcare Ethics at St. Louis University. Jason, thanks so much for joining us today.
Yeah, thank you, Brian, and thank you all who are in attendance today. So Brian asked me to kind of lead off this discussion because early on in the pandemic, I was involved with a couple research studies sponsored by the Association of Bioethics Program Directors. One was just a survey of ethical issues, just kind of looking at the existing literature and the literature that was emerging early in the pandemic about just what broad-based ethical concerns we should have about resource allocation, about care of healthcare workers and their duties and balancing their duties and their rights. And then looking forward to, things that we're facing now, like the vaccine development and distribution of the vaccine, how to do that justly and fairly. The other study, which was published in the Annals of Internal Medicine, was an empirical study of existing and emerging triage policies or crisis standards of care. Interesting thing about that study off the bat is that the vast majority of colleagues that we reached out to, about half of them worked at institutions spread across the US that either didn't have crisis triage policies or were in the midst of drafting them, which immediately just spoke to how unprepared everyone was for this crisis, despite the fact that we had earlier, much smaller scale outbreaks of like H1N1 and SARS and so on. So we're kind of surprised at just how unprepared healthcare systems on the whole were for this. Speak just a couple minutes about some of the ethical issues. Of course, the first thing is, what are your triage criteria? And are you using an objective medical-based criteria? And if so, even if you are there other potential problems with using such criteria? So for example, a pretty wide-based criterion, at least used in adult cases, is what's called the SOFA score, the Sequential Organ Failure Assessment Score. And this is widely taken as, again, an objective, empirical criterion to distinguish which patients were in the greatest degree of medical need, balancing that with their likelihood of survival. But already there were issues because SOFA scores were not developed to be used in triage circumstances, so they've never been, this measure never been tested and validated in that context. Two, lots of things can affect your SOFA score besides whether you have COVID or not. So you might have other comorbidities, right? Things like high blood pressure, diabetes, heart disease, COPD, and so on. And one issue there is that a lot of these conditions are either concomitant with some sort of disability. So now you have a concern about disability discrimination, or also are associated with disparities in healthcare access. And so you have members of poor communities, minority communities, who are experiencing higher rates of things like heart disease and cancer and so on, who are now going to be sort of double whammied because their SOFA score may not be as good as others. So lots of other conditions other than just COVID were affecting how people were performing in these measurements. And so that's one problem. Another problem is that you might have, again, if you're experiencing a surge and you have multiple patients in need of ventilators, what do you do if patients have the same or relatively similar SOFA scores? What sort of secondary criteria you're using? And here's where we saw a lot of variation in secondary criteria. A few, for example, would use age. Not in so much like, you know, a 50-year-old beats out or 49-year-old beats out a 50-year-old or something like that. But the idea that maybe someone who's in their 20s might be prioritized over someone in their 60s or so on. And this is based on an ethical principle that's been put out and is very controversial about fair innings, about, you know, who's had a fair chance of living through life's various stages. Again, not very many policies use that, but some did. Others would use secondary criteria like first come, first served. Well, there you also have problems because, again, you might have people who don't have ready access to healthcare because of some of the disparities, access disparities I already mentioned, or they live in rural areas. So that prioritizes people who are in urban areas and are able to get to the hospital, you know, more quickly. Or you have people who are doing what they can to not get infected, so they don't get infected early on, but then they can get infected later. So first come, first serve has some problems related to it, which is why then some policies just say, let's resort to a lottery, which, you know, is arguably a fair way to do it, but is also, you know, a blinded, you know, way of doing it. And some ethicists would argue, well, maybe there should be some rational choice involved here. Maybe we should use some, you know, different types of measures. But again, pretty much any measure, even the putatively most objective type of measure for resource allocation is, as I already mentioned, going to have some inherent problems. So all this is to say that there's no perfect triage policy. And most of the policies we looked at for that and other reasons tried to build in some safeguards to ensure equity and fairness. So for example, triage committees should be appointed. This shouldn't be a decision that doctors at the bedside have to make about their patients. You know, the idea is to preserve the physician's duty to care for every patient in front of them. And so it's not about forcing physicians to have to make these decisions, but appointing a triage committee who basically determines how the resources are getting spread out. And so the physician, of course, can only use the resources they're permitted to use. And that's kind of what the triage committee is doing in this context. And another question related to that is whether the triage committee should be blinded to any information about the patients they're deciding on, other than the relevant medical data. And although there's a broad ethical consensus that that should be the case, this should be a blinded process on the part of the triage committee, only a few policies we found actually explicitly stated that it should be a blind process. And then finally, there should be a process of appeal. And every policy had some form of ability for the patient, or more likely the patient's family, to appeal a decision to unilaterally withdraw a ventilator from a patient in order to reallocate it to another patient. Primarily just to ensure that the process was done fairly and equitably. So with that sort of just broad overview of some of the data we found in these studies, I'm, you know, certainly during the Q&A, I'm sure we can get in a lot further detail. So I'll turn it back to you, Bryan.
Jason, thanks so much. I mean, a really helpful overview for folks who have both been involved in this and for folks who are coming to see some of these broader considerations. One of the comments that you mentioned sort of pointed to some of the challenges in access with respect to rural populations. So I'm going to turn now to our next panelist, Dr. Thomas Harder, who's the director of the Department of Bioethics and Humanities at Gundersen Health System. He is also the president of the Academy for Professionalism in Healthcare. So Tom, thanks so much for joining us. I want to turn it to you with a sort of an eye to the rural population that I know you serve and that Gundersen serves. So what have you been seeing on the ground? How are you thinking about sort of this big wave of COVID and the surge that you guys are facing? Help us think through this.
Yeah, thanks, Brian. This is a fantastic opportunity. And I also want to thank Jason. I had the opportunity to participate with Jason on some of those projects with the ABPD that he mentioned. And I was one of the institutions that provided him information for the study he was just talking about. And we were also one of the institutions that, as Jason mentioned, didn't have a plan in place. All right. What we had here in Wisconsin and at Gundersen in particular was coming from the H1N1 pandemic from 2009 with recommendations saying institutions should develop these protocols. They should have these triage plans. Here's what they should look like. Here are some guidelines for doing that. And then relied on the institutions to do it. And many institutions, by the time that pandemic was over, it became less of a priority and didn't do it. And so we found ourselves in that position where very rapidly in early spring, we're getting emailed from our administration, myself and my medical colleague, Dr. Elizabeth Cogbill, and being told and asked, do we have this? And if not, we need something right now. And so we scrambled and started getting these plans together, and they evolved. They developed and evolved very quickly over the course of a few weeks. But I think, one of the things to be mindful of too is with all of the institutions that were mentioned of saying we're developing these plans, many of those plans were preliminary and weren't finalized in that final report. And so it'd be interesting to go back now and see what of those plans, what's been modified, did they do anything with them, did they bring them back to the community to have the community vet them? And that was one of the other big recommendations in terms of equity and equality that has been recommended, was to come back and have community involvement in those conversations. And I can tell you, we have not. And part of the reason we haven't is because while we were going through early summer with the lull here in Wisconsin, it wasn't huge in terms of the pandemic, right? And things seemed like we had slowed the spread, right? And we were all feeling really good about ourselves. We had done it, right? We slowed the spread and things were going okay. And then August hits, and slowly and then very rapidly our cases started rising. And if you look on any map right now of COVID severity across the United States, the upper Midwest, we're getting hit the hardest. And if I look like I have bags under my eyes, I do. And that's because we're all exhausted. My medical colleagues are dropping like flies. And so when we talk about resources and expenditures, the worry that we tended to focus on in the spring and is still a worry, right, is worry about equipment, right? Worry about PPE, worry about ventilators and space. And what I can tell you from our firsthand experience, what we're going through right now with a massive surge in the upper Midwest, and particularly in La Crosse, where I am in Wisconsin, it's staff. We are having staff who, because of our COVID protocols, are needing to quarantine or isolate because of exposure. This is public knowledge, so I'm not saying anything here that is private or institutional. We have over 500 of our care providers right now, over 500, who are isolating it and or in quarantine, who are not on the floor, on the units right now, providing care to patients. That is a substantial portion of our healthcare providers. And what that does is, of course, it puts strain on everybody else. So we're seeing more patients, we're having a huge explosion, and we're having fewer people to be able to provide that level of care. Space is somewhat of a concern, but less so. we've maxed out in on our COVID unit and units. We're developing more. We have adequate space to develop more of those units. But as we develop more of those units, that means we're providing and taking space away and reallocating the space effectively for providing COVID care. So are we going to get to a point like you saw in New York or in Italy where we were having tents outside? No, I don't think we're going to get there. But what you are going to see is a decrease in services in other areas of the health system. And this is something that I think faces many rural institutions. So as the bigger institutions get swamped, that is, it means that they can't accept patients on transfer as readily as they normally would. So what that ends up doing, and talking about the wake of COVID-19 in your communities, it puts more pressure on your rural hospitals and clinics to keep patients there, not the clinics so much, but the hospitals to keep patients there, and particularly in the nursing homes, right? And trying to manage outbreaks in the nursing home at the places that those are occurring. So my colleagues who are providing nursing home care, who are dealing with outbreaks in all of the nursing homes here locally, they're exhausted. Everybody is working 14-hour days, it seems like. They're very tired. And when people get tired, they are not able to provide care to patients as adequately as they would like, right? It's just a fact of the matter of being exhausted. What also worries me is they're not providing care to themselves. They're not getting adequate rest. They are being stretched. We do worry significantly about burnout. I worry very much less about burnout and more about moral distress. We've begun a program here that we just started where we're focusing on residents, where we're essentially setting up webcast opportunities, like little Zoom meetings that are very much like the RISE program that comes out of Johns Hopkins, Resilience in Stressful Events, where we're giving people the opportunity just to talk about their experience and to have an opportunity to say, this is what I'm facing, this is what I'm worried about. There's no expectation for, and nothing's being recorded in those, just people being able to say, here's why I'm worried. We're hoping that helps a bit, but it doesn't, of course, address the beast. And the beast here in the room is we have a pandemic, it's getting worse, and yet some people think it's getting better, and they're not doing the things that we need to do publicly to address that. And because of that, it is putting that strain on the health systems in ways that I worry, much like we did in early spring, we will get to a point where we do have to make those decisions about who gets treatment and who doesn't. I'm going to turn it back over to you, Bryan.
Thanks, Tom. That's really helpful. I'm especially appreciative of some of those positive suggestions because the students who call in are always asking about what can we do, what sorts of things are being put in place. So those kind of programs and hearing about what you're doing at Gunderson, it's helpful and it's a nice model. Also very appreciative of the focus on the human beings who are doing this good work. It's a theme for those of you who call in regularly. That was our sort of first big COVID ethics series episode, sort of balancing considerations of risk and duties to care. And the focus on the human being, Tom, is most welcome. Since you addressed well the rural, sort of some rural considerations, we're going to now move to my colleague at HMH and in the med school, Dr. Hannah Littman, who is the Vice President of Bioethics at Hackensack Meridian Health. Hannah, thanks so much for taking the time to be with us today. Tom gave us the rural focus. Could you talk through, clinical bioethics, what you're thinking about as in Jersey, New York, and the Northeast, this sort of second wave starts kicking up and resource allocation?
Yes, thank you. Thank you, Bryan. Thank you, Tom. Thank you, Jason. It's my pleasure to be on the panel. A couple of things. First, I just want to pick up where Tom just left off and say that, and I'll talk about, the issues of policy and give a perspective from a clinician. a physician bioethicist. But the most important takeaway message, I think, from this session for the general and interested public is that, to a certain extent, how overwhelmed our hospitals are is in our public's hands, that we all really need to be doing the wearing a mask and the physical distancing and foregoing gatherings, as painful as that is, for Thanksgiving and things like that. Because we never want to be in the position of choosing who gets what resource from among all of the people who would ordinarily get it in usual times. So we did experience, the surge, very obviously in the spring, and the hospitals in New York and New Jersey were, quite overwhelmed, and we suspended, like all of the tri-state area hospitals, suspended elective procedures, and there was a significant decrease in the numbers of patients coming in for non-COVID. So I also want to emphasize that when we talk about COVID patients, a surge at our hospitals, we're also talking about the ability to care for usual elective things. We were always handle the emergency things, and that was more of a matter of patients not coming for their emergencies. But elective things, would be suspended. That is not the case now, and we hope that it won't become the case. So, in addition to doing our part, everyone doing their part, and thinking about not only the impact on COVID care, but the impact on healthcare in general, I will say also that New Jersey in April, like many states around the country, as you heard from Jason, started to say, okay, do we have a plan? Can we dust off some of the plans that we had for after SARS or H1N1 and adapt them for the coming COVID surge? And New Jersey is no different, and they adapted a policy that was written by Doug White and his colleagues for the state of New Jersey. And I want to think about, just put this out there, to think about what entity should have such policies. And you heard from my colleagues a little bit about the challenges in developing a policy quickly, and the variation from Jason in the policies. So I think in terms of institutions, it's really institutions partnering with our state, and government entities, so that a policy is consistent across a region is important. From a clinical point of view, why do we need these policies in the first place? So there was a lot of popular attention from the popular press back in the spring about running out of ventilators. There were articles in magazines and in the New York Times and in the Washington Post, and it became a hot topic among the public. And I think that was very important, actually, because the public is who is impacted and by the policies that are put in place, and engaged, as Tom mentioned, an engaged public is really, really important for making sure that the priorities that are embedded in our policies reflect the priorities of our communities and reflect the concerns of our communities. So that public attention, I think, was very important. But what, we're used to, if we get sick, we come to the hospital and we assume that whatever we need will be there. And I want to just take this step back for people who haven't been, immersed in thinking about scarce resource allocation for the last 8 months, who might be on the call. And so we, the treatments that are offered to a person are dependent on what will benefit them based on what they have. And their own personal values about what burdens of treatment are worth going through to achieve what outcomes. And the issue that we're talking about here is that when there isn't enough for everybody to be able to make their own personal decision about what burden of treatment is worth it, because the decision is imposed upon them, and I'll just use the example of ventilators, there's a few too few relative to the patients who need them. We need to shift our ethical underpinning from honoring patients' values in the conversation about benefits and burdens to using what we have to benefit the community as a whole. If in the issue of absolute scarcity, if we just took every patient as they came, first come, first served, and said, okay, what are your values? You think, based on your prognosis, which seems to be good. And one issue in the early COVID days was that it was really a new disease, and we were rapidly learning clinical treatment and outcomes as we went. But we shift from that very individual patient-centered type of decision-making to that population decision-making. And that is very, and Jason mentioned that the policies mention triage committees or triage teams, and that the decision for allocating which person gets a ventilator and deciding how to evaluate this group of people to make sure we use whatever we've got to benefit the group as a whole is taken out of the individual clinician's hands, because that individual clinician's responsibility is to advocate for that one patient in front of them. But that is a very uncomfortable shift. And I want to emphasize, though there is a state policy that's been adopted in New Jersey, to my knowledge, no, we did not need to implement it. But there were places that came close where they saw the surge happening. We didn't know how fast the curve was going up. We were, tracking and surging and sourcing, and you saw, our governors in the region on TV all the time talking about sourcing, and I'll keep using ventilators as the example, and that was a hot topic, and we stayed ahead of it. But that moment in what we would call contingency standards of care, not crisis. We have ventilators for everybody, but we're, staffing is an issue, and lots of patients are coming in, and we're not sure how close we are. Those that contingency level also has significant ethical issues. So the policies talk about what happens when you have to choose from among all the people who might benefit from a ventilator because you don't have too many, but shepherding my clinical colleagues through how to think through maintaining a focus on individual values, even though they were worried about running out of ventilators, that concern, even though the triage teams are supposed to alleviate them from that responsibility about thinking about the group and the individual at the same time, there's no way that clinicians can do that knowing what's coming. And just psychologically. So shepherding them through maintaining a focus on individual-based decision-making while we still had supplies, but strengthening our ability and our efforts to talk through the very real choices that are facing critically ill patients about what burden is worth going through, especially those who have comorbidities, who may have a grave prognosis, especially with this new devastating disease. So keeping my colleagues focused on individual decision-making, educating them about what was coming and what the policy had to do, what the policy would do if it were needed, was also deserved a lot of attention, not only the attention about what happens once we run out. And I have more to say about the implementation, but maybe I'll leave it for the questions. I'll just give a teaser and say that the policies are developed in theory, and implementing them on a large scale is logistical challenge. And it's also a challenge because you're planning for something, and this is true of all disaster planning, you're planning for something that you're also planning not to need. So in addition to the public doing our part, and I'll put myself in that category about doing everything we can to stop the spread of COVID, our systems have done everything possible, and our state Department of Health has done everything possible to be able to meet the patient's needs, even as the case numbers start to rise.
Anna, thank you so much. It's super helpful. And it's great having a colleague who is both, the integrated bioethics hat and is a physician to really expand our perspectives on this. So with that in mind of expanding perspectives, we've had our broad framing. We've had from two different areas of the country, a clinical ethics, consideration, focus, broad policies. Now what I'd like to do is shift our attention a little bit broader into a perspective that I think hasn't been addressed as much and needs to be. So we have with us Dean Kathleen Buzang, who is Dean and Professor of Law at the Seton Hall University Law School. Kathleen, thanks so much for joining us. It's great to have you here. Help folks on the line who've thought a bit about some clinical ethics, notions and considerations in light of what our three panelists offered. Shift our perspective. What might folks who sit on hospital boards, and boards in general be thinking about, and what should they think about?
So this has been a sad, tragic, but interesting experience for me, because I served on the New York State Task Force of Life and the Law when in 2007, we developed an allocation policy specifically focused on ventilators. And I was on a board through the pandemic, a hospital board. And so what was originally an academic exercise became real life. And that raises the question then that we started with. Jason said, why weren't we prepared? It's not that we didn't know this could and would someday happen. And it's not that people hadn't prepared, but at the provider level, as we've heard, there were many gaps in our preparation. So the question I'm raising is, whose responsibility was that? So ultimately, the law says that the entity with the ultimate responsibility for what goes on in a hospital or a nursing home is the board of directors. And but we don't have much law telling us what to do in these kinds of circumstances. And so, in fact, even at the board level, many of the questions that arise and that we faced are indeed ethical questions. And so I'm going to just briefly talk about 4 things that I think have ethical implications at the board level that impact and should inform how we go forward. First is stewardship of resources. Second, obviously, is allocation policies. Third is what boards are doing in their facilities regarding social determinants of health. And fourth is protecting the health and safety of workers. So first, to go to the stewardship of resources, on the one hand, and I've always served on safety net, the boards of safety net and urban hospitals. And so when you're thinking about preparation for something like a pandemic or a biohazard, on the one hand, if you're on the board of a hospital that just desperately wants to have a margin, is desperately trying to break even, it is really hard to step back and take a pause and say, let's invest millions of dollars in preparation for a pandemic or a biohazardous event. And so that raises the question of whose responsibility in our healthcare system, I frequently refer to it as a faux system, for this preparation. And I won't get into detail, but we do have laws that talk about the responsibility of the federal government, the state government, and providers. And in fact, you may remember Mr. Jared Kushner's remarks that talked about the federal stockpile and said that's our stockpile. And then soon after that, the federal website got changed with respect to who got to take advantage of those resources. But ultimately, the question still remains, irrespective of what the relationships are as among the state and federal governments and individual providers, what should hospital boards have been doing in advance? And I fall into the habit of saying hospital boards, but what happened in many states in the long-term care setting, I won't use the word criminal because that might be perceived as hyperbolic, but I'll say tragic. So I'm talking about all of those boards. So we knew that a pandemic or a biohazard it wasn't an if situation, it was a when situation. And it's like going without insurance, not to have prepared, and no provider would go bare, as we call it, without insurance. It's also the case from a stewardship perspective that the cost of PPE would have been 17% of what it ended up being had it been bought in advance and had been stockpiled. And during the pandemic, I can tell you that hospitals across the country, the boards were approving expenditures, just hoping that the government would intervene and reimburse. They were spending money they didn't have because they felt they had no choice from a saving of life perspective. And they ended up spending more. And then it gets to the question of, well, how much do you stockpile and what do you stockpile? And we've seen a couple of states since the pandemic, in the fall, not even during the summer, pass some laws giving guidance 90 days of PPE. And interestingly, they don't go to equipment. The couple of states that have addressed it have talked about PPE and not ventilators. But that question still remains going forward. What should hospital boards be investing in? A second part of the stewardship question is should hospitals, or how should hospitals have shared resources? So for those hospitals that did have PPE or equipment and the pandemic hadn't hit them yet, we did see sharing, but was it being done equitably? We know that some hospitals continued to forever through the pandemic in urban settings, and I'm going to guess in rural settings, I don't know as much about that, never had enough to make it through. And so what's the ethical responsibility of providers to have shared? And then sharing of personnel. I know in our area, in the metropolitan New York area, we did get personnel coming from other facilities across the country. But when it came, once our first wave ended and the first wave was hitting other parts of the country, we talked a lot about PTSD, of sending our personnel elsewhere when we knew we would be facing a second wave. Across zip codes in particular regions, we know that in geographic areas that are mere miles apart, that the death rate in some zip codes, at the hospitals in some zip codes, was much higher than the death rate of other zip codes. Did we have enough sharing of PPE, equipment, and personnel across those zip codes? Now, this particular virus did not hugely adversely impact newborns and pediatrics, but that I wonder how many plans that have been put in place for ventilators addresses children, infants in particular, because the ventilators for small babies and peds are different than we use for adults, and many healthcare professionals don't know how to intubate young children. And so if we're thinking about gaps going forward, go back to your policies and see if that's been done. With respect to allocation policies, I'm not going to get into the bioethics, the clinical ethics that were just addressed. My point is, however, that I believe that boards have an ethical responsibility to approve those policies. And so I think a really interesting study would be how many boards, because these are hard decisions that impact communities and are about life and death. And it is ultimately, in my view, the board that should be signing off on these policies and should understand what they're doing. And has such planning, what are the board responsibilities going to be with respect to vaccine distribution? Social determinants of health. A lot of us have been talking about it more recently, but we saw that COVID absolutely disproportionately impacted Black and brown people, certain zip codes, the hospitals in those zip codes, long-term care facilities, and prisons. So what is the ethical responsibility of boards? To look at those specific populations and make sure that investment is being made so that we don't see the devastation on these vulnerable, particularly vulnerable populations again. And finally, protecting health and safety of workers. And that again is a very nuanced question. Obviously, we could be talking about frontline workers, but I suspect that many of the workers who died, in addition to frontline workers, were indispensable workers who are your lowest wage employees, living in zip codes and under circumstances where they were vulnerable in their living settings. We desperately need them to be cleaning facilities and doing other things. And so have we talked about what providers' responsibilities are to that population? And then the last thing I'll mention, although this is just a gloss of some of the issues that I think boards need to be talking about, many boards ended up simultaneously making decisions to provide hazard bonuses to frontline workers while they were simultaneously laying off other workers. And I think that's a really difficult ethical question that hopefully I'll have time to explore and share on. So that's my 10,000 foot, why weren't we prepared? Who owns that responsibility? It's the boards of facilities working together with the states and federal government.
Kathleen, thank you so much. The perspective focusing on a board is super helpful. And for those who call in regularly to each of our episodes, have heard the importance of paying attention to the interconnectedness of a variety of systems in response to COVID. So we saw this in our last episode. Dr. Florian Thomas and Professor Michael Guzmano sort of highlighted how one thing impacts another. So I appreciate your broadening of our perspective. We're now going to move in and just sort of go through a couple of questions and ask of our panelists. We have a bunch of questions that have come in advance of the session. You're welcome for folks going in to tweet us and send further questions in as well. So the first question I have is actually for Jason. So Jason, you had mentioned sort of the studies that you had done early on in resource allocation. And I'm curious if that work that was done gives you any guidance, if you can share that with us, or sort of how it affects your thinking about a second wave. Was that sort of, do the studies give us any information that might help folks better plan?
Mm-hmm. Yeah, I think one of the key outcomes of our study, which again was done very early on in COVID, and even the policies we were able to look at that were shared, with us by colleagues like Tom and so on, were by and large in draft form. And thankfully, as Hannah mentioned, a lot of these, we didn't really have to implement, thankfully, a lot of these policies in the first wave, although we got very close. And one thing I don't know, and this would be an interesting study to do right now, is how many hospitals, healthcare systems use the time, the kind of lull. I mean, there was, somewhat of a lull now, to take the time to look back at their policies. It's kind of rushed and hurried, maybe. Coordinating with other colleagues to kind of see what best practices would be, and also doing that community engagement. I think Tom and Hannah both mentioned that is vitally important. I think the main takeaway for people from this is that given the diversity that we saw in the policies, especially among the secondary criteria, and like I said, there are some issues even with using as a primary criterion for triage, something like a SOFA score. If you don't want to be if a person doesn't want to be accidentally have their loved one triaged using one of these criteria, and no one does, obviously, then the key is to stay out of the hospital, right, as much as possible. And the data we're seeing now, I'll just kind of represent what's happening in St. Louis, because Missouri's become one of the main hotspots in the country right now. What we're seeing a lot of right now is the rates within St. Louis City and St. Louis County have remained relatively steady. There's an increase, but not a super sharp spike among the populace. But our urban hospitals, so St. Louis University Hospital right across the street from me, Barnes Jewish Hospital in Midtown St. Louis, they are, between those two hospitals, there's about 1,600 beds. And we're up to 838 total admitted patients for COVID right now in the city. And that includes more hospitals than just those two, but those are our two largest. So the point is if you then add in people who are admitted to the hospital for other things that are non-COVID related, you can see that the hospitals are nearing capacity. And a lot of the patients we're seeing are coming in from more rural areas. Some rural counties have infection rates that are double the rates in St. Louis City. And so that's kind of the differential we're seeing, right? We're seeing this lag of maybe areas of the state or in other states of the country where maybe people were a little bit complacent, not practicing good PPE or not PPE, but good preventive measures because either A, the virus wasn't a big deal in their area, and so, like I said, they were complacent, or B, they had a political objection to mask wearing and so on. And so, again, no one deserves to get COVID. No one deserves to be in this situation, and no one should be blamed for having to be hospitalized now. And obviously everyone should be treated as they come in as far as possible. But the point is, as we reach limits, and if we have to implement these crisis standards of care, there are going to be some very unpopular decisions made. And even with community buy-in, again, one may agree in principle, yeah, triage is necessary, this seems a fair policy, but when it's you or your loved one who's potentially going to have a ventilator unilaterally withdrawn from you because your SOFA score isn't that great, you're not going to want that to happen. So that's kind of my takeaway lesson.
Thanks, Jason. That's helpful. And I think you've sort of set up a natural segue to return to Hannah's comments about implementation, right? So we can talk about this in theory, and we've seen, many folks have seen this. So I want to turn back to Hannah and just ask her to, Hannah, help us think through again the implementation in light of all we've talked about so far, at least as you've seen it.
Yeah, well, I'll just talk about, like I said, we haven't had to implement the policy and hopefully won't. But the question, as with all disaster planning, is how much do you do in preparation? And I really appreciate, my colleagues and especially Kathleen's comments for those, that other angle on who's responsible for ensuring that preparation happens. In terms of implementing, the policies vary on who makes up the triage teams. And as Jason is emphasizing, what is in the clinical evaluation of the patient. So as I said before, the point is we have a limited resource, and I'll just keep harping on ventilators because they're discrete and easy to wrap your mind around, and it's easy to understand, why you would need one. The question is, as I said before, you use your limited pool of ventilators to benefit the most people. And the questions there are, what is benefit and how do you decide who is going to benefit? And that's some of the implementation concerns that Jason is mentioning about this clinical risk score or clinical disease severity score called a SOFA score. Other parts of the clinical evaluation that is set by policy is, how do you account for somebody's other medical problems? And some of the other panelists touched on, when you think about social determinants of health and who's likely to have more burden of disease, the concern is that if you are assessing someone based on their ability to survive this episode and incorporating their overall health status, then some of the consequences of our healthcare system or our healthcare system and the social determinants of health are there. So that's a significant concern. But then again, in realizing your primary obligation to benefit the most people with what you have to make some determination about who's likely to benefit and what that looks like in near-term survival or medium-term survival. There's consensus that looking out past just an estimate of prognosis past a few years is too uncertain and too impacted by factors that could lead to an unfair policy where the unfair burden was being placed on people who had already been hit by COVID, already hit by the social determinants of health. So there's thinking about that clinical evaluation. There's also, you want people on those triage teams who are clinically knowledgeable, and those people are needed to treat COVID patients. It's nice in theory, and I understand the theory about why we have triage committees or triage teams doing that, but the reality of a COVID surge is all hands on deck, and it's hard to pull people to, well, we haven't had to, but it's even hard to contemplate pulling people to this role when they need to be at the bedside treating critically ill patients. So that's an implementation concern. Other implementation concerns that I'll just touch on, the features of these policies are triage teams, clinical evaluation for initial allocation of a ventilator to a patient, still use ventilators. Then there's reassessment, and Jason alluded to this, all the patients who are receiving it, if after some time it looks like that's not going to help restore the patient to health and the patient might die anyway, even though they maintained on a ventilator, then maybe we need to reallocate that. That's very, very difficult. So there's the thinking about how you communicate with patients and families in that precious moment. And in our triage team training, which is required with the state policy, we did a special session on communication with patients and families, because our obligation to care with love for people is not dependent on whether they get a ventilator. So that is an obligation to every patient that we have. So we focused on that in our training. And there's also the review process and appeals process. And the appeals process was briefly mentioned, so I'll just say something about review, which is, how do you know in real time that this is being done consistently and fairly? That's very, very difficult question to get at and get the data in real time. So we've spent some time, thinking about how we would oversee the process and do that review process should it be needed.
Excellent. Thanks, Hannah. That's super helpful in thinking about how the implementation might occur. I want to shift now back to Tom Harder. Tom, it's a two-part question. Part one is, sort of following up on Hannah, are there any specific sort of possible implementation concerns given rural areas? And then I want to quickly move us to some professionalism considerations. So I'll ask you that question, but first, anything sort of following up on Hannah on rural areas?
Yeah, thanks, Brian. I think so. The thing that became evident to me through the early stages of the pandemic is we were beginning to see potential shortages in other areas that weren't obvious, perhaps at the front end. So a lot of our brain power was focused on ventilators. And what ended up being the case in midsummer was we ran out of blood. We ran out of blood product because people weren't donating and they couldn't get to the centers. And there we did have to implement our crisis standards of care. We did have to implement our triage team. My understanding is there wasn't any patient who needed blood who didn't get it, but we did have people that needed to be diverted away from the hospital to other institutions to get the care that they needed. And that was just the nature of the integral healthcare networks that occur, right? And so in terms of implementation, we had a little bit of practice with it. It seemed to go fairly well. I think Hannah's absolutely right when it comes to right now, in the midst of a surge, everybody's all hands on deck, beginning to try to implement that, and to have the triage team have the brain power and disassociate themselves from the roles that they have when they're not on the triage team, I think is going to be a different story if we ever have to rely on them.
Thanks, Tom. That's helpful. And I want to sort of do a shift for a quick comment because we're going to come close to our deadline soon. But in thinking about the moral distress that you highlighted earlier, and as folks are, when implementation, if implementation happens, right, the moral distress and the stress increases. When we think about this, we often think about professions. So if you could put on your president of the APHC hat, any sort of key professionalism issues, anything that's on your mind, any recommendations in thinking about the professions, the health professions who are really engaged with COVID on the front lines?
Yeah, trust. Trust is the first thing that comes to mind. We're on the verge of having a COVID-19 vaccination. We know there's hesitancy, right? What that equates to is there's questions of trustworthiness. Providers on the front lines some of them are angry and bitter, right? Why aren't people doing the things they need to do, right? We don't trust that people are doing the right things, and vice versa. We have people in the public going, I don't trust public science, right? I don't trust that the providers are really interested in doing what they say they're doing, right? This is all just for lack of a better term, a conspiracy of sorts. So there's a lot of distrust, and we're seeing many ramifications of that, where I think our providers are trying to look past that and continue to provide the care. As Hannah said, the goal is love and care, right? And that we try to separate our personal feelings from the patient in front of us. But I think there's residue there, right? And as a professionalism issue, that's something that we have to continue to work on, is how do we establish trust? How do we maintain that? How do we encourage a culture of trust, not just within our organizations, but across the professions that permeates through the general public?
Excellent. Thanks, Tom. Super helpful, and especially helpful for me because this is a subject we're talking about in some of the ethics courses I'm teaching, and a bunch of those students are on the line. And I know, and we'll put some resources up for folks who are interested. I know the APHC has a big conference coming up focusing on trust, and we'll make sure we have that in our resource section, and anyone's welcome to our library page to check out that information. So the last question, as we're sort of short on time, I want to turn back to Kathleen. Given the challenges that everyone's going to face in the second wave or the primary first surge in other areas, the suggestion that, or sort of in light of the fact that boards have this responsibility, this ethical responsibility to be involved in the ways that you articulated, I'm curious if there are any obstacles that you foresee boards will run into or systems might run into in implementing that idea.
I think that especially, boards are not supposed to get involved with management. Boards are supposed to be at a 10,000 foot level, articulating policy, making sure there's enough resources. So obviously the resource question is going to be huge. Hospitals got a lot of money following, as part of the CARES Act. What they did with it, hopefully it's sitting in the bank or being spent on stockpiling up again for the second wave. The money got distributed in weird ways. So it could be that we're going to have some resource stretched facilities. Secondly, I think that it could be the case, I would love to know what Hannah says, but that clinicians developing these policies, implementing these policies, don't understand why the policy would have to go to the board for approval. Why is the board getting involved in clinical decision making? But in fact, they're at the policy level, knowing that we are diverting from our usual standards on how we take care of patients and make decisions respecting an individual patient and looking at things from the greater good perspective. And third, I think the biggest challenge is sharing resources. I suspect that there were entities that hoarded. Don't know that for a fact, hope not. But sharing resources, especially across zip codes, your wealthier hospitals to your hospitals that are struggling, hospitals to nursing homes, what kind of support were acute care providers providing to long-term care, to prisons, to other places. And that's outside the usual lane of most providers and most boards. That's requiring us to, in some respects, build from scratch. And that takes a lot of time, effort, and thought.
Thank you. Thank you very much. And I see that we are just out of time. So I want to thank all of our panelists for joining me today and for the helpful comments. I know many folks on the line know of the great work that our panelists are doing in their own areas. And we really have, it was very fortunate to have a number of really heavy hitters on this. So I appreciate that very much. For anyone who's interested, we now have a COVID ethics series podcast. So for all of those who wrote in and said, hey, how is this not a podcast? It's now a podcast. You can listen wherever podcasts are sold. Also, this, as I mentioned, is our final episode of season 2. We're going to pick up with some interesting and important work on vaccines, on narratives in COVID, a number of other topics when we return for season 3. And one of those big highlights is a plug for our podcast. Carl Coleman from Seton Hall's Law School and I have a long conversation. So we've got some new additional content on that podcast about vaccines and in particular challenge trials. So anyone with questions, please feel free to email us at ethics@shu.edu. Check out our library webpage, join our listserv, follow us on Instagram and our student accounts on Instagram and Twitter. And again, thank you so much to all of the panelists. Thanks for folks who are calling in, and I hope everyone has a good day.
Thank you, Brian. This was fabulous. You're a great assembler, moderator, and leader.
Thank you, Kathleen.
You're here.
Yes, you're here. Thank you, Brian.
Thanks, everyone. Thanks. Good to see you all, and please be safe.
Take care, folks.